Hello, welcome back. Dr. Adam Rosen today. If you haven't already subscribed, please subscribe. And if you like this information, click the thumbs up button below. That'll help people like you that are looking for this information find it. So today I want to talk about a topic that a few people have commented on, and that's what's called an MUA, or manipulation under anesthesia. So unfortunately, a small percentage of patients after knee replacement will develop stiffness. So what is stiffness? I mean, stiffness is the inability to bend. But when it comes to a knee replacement, what is normal? So normal knee replacements around the world get on average 115 to 120 degrees of bending. But a lot of that motion is dependent on therapy, also on your pre-op range of motion. So somebody that only has 70 degrees of bend may not get full range of motion, as opposed to someone that has a lot of motion before surgery because their tissue is more elastic, it's more supple. But the other issue is biology, and we're not always sure who's going to lay down a lot of scar tissue. So in a knee replacement, there's metal on plastic. So I've never seen the metal stick to the plastic. But what happens is when you have the knee replacement, in the spaces in the front and the back and the sides, you will bleed in the knee joint after surgery. And that blood, if you don't move the knee, will start to solidify and it can form scar tissue. And then the surfaces from A to B, sometimes they get stuck to one another. And although the plastic and the metal want to bend, there's tissue that will not allow it. And we call that stiffness. So the definitions of stiffness in our world change as to, is it an arc of motion from here to here? Is it a limited motion that doesn't go to 90? Most importantly, though, it's failure to progress. So if somebody is making progress, but slowly, we tend to give them time and work more aggressively with physical therapy in the hopes that they're going to get better range of motion. But again, and you've heard me talk about it before, your best chance at getting range of motion is early. The earlier you get motion, the less risk of stiffness and the less risk of scar tissue building up. So work on the motion early. But if you're starting to get stiff, you want to meet with your doctor. If you're significantly stiff, where you're failing to progress, and you're not able to move the knee, it can be a dysfunction, it can be a disability, and then you may be recommended something called an MUA, or manipulation under anesthesia. So what will happen is you will come into an operating room. Usually you will get put under some type of anesthetic so you can be relaxed. And then the doctor will take your leg, lift up your femur, take your shin bone, and if this is 90, if you're stiff, I mean, you might be like this. You might not even have 90 degrees of motion. That's why you're in the operating room getting manipulation. And they'll gently put their hands here, and they'll push, and they'll push, and they'll push, and they'll push. And what we hear or feel is, and you'll feel little pops of tissue, and usually it kind of jerks a little bit and a little bit and a little bit. And the goal is to try to bend it back as far as it can go to get the tissue to move again. And then you get woken up and off to the recovery room, and then home or off to physical therapy. Now, occasionally a doctor may inject it with some numbing medicine. Sometimes people will also put a camera in there and do an arthroscopic release, just like you would have for a meniscus surgery. They put a camera in there and try to debride around the tissue. But the bulk of the time, it's going to be just that manual force of bending the knee to get you more range of motion. So does it work? Well, depends. If you have a manipulation, most people will keep half of what they get. So let's say, for example, you had 80 degrees of bend, and at the time of the manipulation, they get you to 90, they get you to 100, you get you to 110, 120. When all is said and done, you'll probably have 100. Most people lose half of what we get because the scar tissue is still in there. We've stretched it out, but there's the potential to get more motion. You have to work really hard with physical therapy. So you also want to coordinate this with your physical therapist so they know when you're having it done, so they can get you into physical therapy quicker. What are the risks? And this is the thing, is we try to do this within a time frame of 6 to 12 weeks from the day of surgery, because there's risks of injury. So when you're pushing hard, you can cause a fracture here, or you can cause a fracture here. That would be bad, and it would require additional surgery. There's also, in front of the knee, the kneecap and the quadriceps tendon and patellar tendon or patellar ligament, we call that the extensor mechanism. So as you're bending it, that can rupture, and that would require additional surgery. And unfortunately, all of those things, if they require surgery, require usually a period of immobilization, and putting you in a brace or a cast to let that tissue heal or the bone heal then leads to more stiffness. So luckily that risk is low, but it can happen. And that's also the reason we don't tend to do this beyond that 12-week period. That's a whole nother topic, but if this fails and you're stiff, down the road people will talk to you about what's called an open lysis of adhesions, where they actually open the knee up and carve out the scar tissue to try to get more range of motion. But I hope this just answers the questions that people were curious about as to what is an MUA. So manipulation under anesthesia, putting you asleep, bending the knee. The chance of success of getting more motion, if you gain 40 degrees, you'll probably keep 20. There's a lot of risks, major ones that we worry about. There are fracture of the bone, as well as injury to that extensor mechanism. And then all the other stuff you should really talk to your doctor about to make sure that this is the right procedure for you if you're getting stiff, but talk to your physio, talk to your surgeon, and hopefully this at least answers some of your questions and gets you in the right ballpark as to what might be needed if you're one of those people that's struggling with your range of motion. Thanks again for listening. Stay safe. I'm Adam Rosen. I will see you next time.